My name is L Piquilloud. I work as an intensivist in Lausanne, Switzerland. It's a pleasure to be here with you today and to discuss whether we should, or maybe not, use a tidal volume of 6 milliliter by kilo for everybody. I have no conflicts of interest related to this presentation. ARDS was first described in 1967 as a syndrome. At that time, and during the 70s, the aim of ventilatory assist for ARDS patients was to normalize the blood gases. This required high tidal volume and pressure, and barotrauma were frequent. During the 80s, the concepts of volotrauma, barotrauma, and more generally ventilator-induced lung injury, as illustrated in this picture from the paper of Dreyfus and collaborators, are increasingly recognized. And this leads to the concept of more gentle ventilation, and finally to what we call protective ventilation, using lower tidal volumes, lower plateau pressure, enough PEEP to avoid atelic trauma, and as a consequence of those settings, tolerating some degrees of hypercapnia. And you can see in the middle of the slide that in parallel to this change in the ventilatory approach of our ARDS patients, mortality decreased. When we speak about low tidal volume for protective ventilation, we usually think of 6 milliliter by kilo predicted body weight. Why 6? Because this very famous study published in 2000, compared two ventilatory strategies. The first one with 6 milliliter by kilo predicted body weight, and the second one with 12 milliliter by kilo body weight. And the strategy using the tidal volume of 6 milliliter by kilo of predicted body weight was associated, as you know, with decreased hospital mortality. And since that time, 6 milliliter by kilo is often considered as the gold standard for ARDS patients. And if we look at the current recommendations for tidal volume for ARDS patients, the recommendations published by the French Society of Intensive Care Medicine in 2019 say that a tidal volume around 6 should be used for all ARDS patients. And this was a strong agreement between the experts. The official American Thoracic Society and European Society of Intensive Care Medicine guidelines have recognized that tidal volume should be comprised between 4 and 8 milliliter by kilo predicted body weight. Overall, if we look at the literature, we can say that 6 milliliter by kilo is better than 12, according to the ARDSnet study. And we can say a bit more widely that 4 to 8 is better than 10 to 15 milliliter by kilo. But what about 4, 5, 7, or 8 milliliter by kilo predicted body weight? No randomized studies can answer to this question. This means that we have to look to another approach to decide what is the correct tidal volume for a given patient at a given time. This is what I'm going to discuss during the next 5 to 10 minutes. ARDS is an heterogeneous syndrome. This was already described in the first description of the disease. The authors who described the disease underlined that ARDS can occur following different diseases, as trauma, pancreatitis, or viral pneumonia. And since the beginning, it was recognized that ARDS patients do not have the same compliance, can be very severely hypoxemic or less severely, and have variable outcomes. And more recently, we have recognized that also biologically, ARDS are not all the same. For example, hyper and hypo-inflammatory patterns or phenotypes are now recognized. And we also know, as previously and also recently again demonstrated, that compliance is not always the same for all ARDS patients. And this is true both for classical ARDS than for COVID-19 related ARDS. Overall, in the majority of the cases, ARDS is associated with compliance lower than normal, but not always. As you also know, all ARDS patients have not the same recruitability potential. If we come back to this data from some years ago, you can see that we have patients who have a high percentage of potentially recruitable lung when the amount of pressure put in the lungs is increased. This is the example of the patient in the C panel. And oppositely, we have other patients with a lower percentage of potentially recruitable lung. Overall, as you can see in the left part of the slide, the majority of the ARDS patients have at least some recruitable lung when PEEP was put from 5 to 45 centimeters of water in this study. But again, recruitability is highly variable between the patients. And this is also true for COVID-19 ARDS patients. You have here a group of 25 patients for whom recruitability was assessed using the R/I ratio, which represents the compliance of the recruited lung over the compliance of the baby lung. And you can see that 16 of these patients were highly recruitable, whereas 9 were poorly recruitable. And very interestingly, you can also see that if a patient was highly recruitable at day 1 of the ARDS, this did not mean that the same patient was also highly recruitable at day 5. Thus, ARDS is a very heterogeneous syndrome. This means that one single ventilatory strategy for all ARDS is probably not the best solution. And this concept has been underlined by the study of Constantin and collaborators published in 2019. The idea in this study was to compare a control group with a standard ventilatory strategy independent from the ARDS lung morphology with another group in which personalized ventilation based on lung morphology assessed on chest X-ray or CT scan was applied. And the idea was to deliver higher tidal volumes and lower PEEP in focal lung morphology and lower tidal volume and higher PEEP in non-focal lung morphology. Overall, there was no difference in survival between the control and the personalized group. However, a lot of patients were initially misclassified. And when chest X-ray and CT scan were reviewed, and patients were analyzed according to whether they were correctly ventilated according to their lung morphology, it appeared that being misclassified or ventilated with the wrong strategy was associated with a much higher mortality, as illustrated in the right part of the slide. And this suggests that a personalized ventilatory strategy based on ARDS phenotype could be an interesting approach. If we come back to the idea of the best VT, we know from the baby lung concept that ARDS lung is heterogeneous, that ARDS lung is only partially aerated because they are collapsed alveolar units. We know that reduced compliance in ARDS is mainly due to lung volume reduction and not to major changes in the aerated parenchyma properties, and that ARDS lung is, at least to some extent, recruitable. Conceptually, to optimize minute ventilation while avoiding overdistension, the best VT should depend on the side of the baby lung. The side of the baby lung depends on the amount of aerated lung, can be influenced by recruitability, hip setting, can vary over time, and cannot be predicted by the patient size. Thus, tidal volume of 6 milliliters by kilo predicted body weight probably cannot fit for all. And normalizing tidal volume to respiratory system compliance could give an idea of the functional size of the lung and could help setting VT. This comes to the driving pressure concept. As you know, the respiratory system compliance is equal to the tidal volume divided by the plateau pressure minus total PEEP. And if we write this equation a different way, we have tidal volume over respiratory system compliance equal plateau pressure minus total PEEP. Plateau pressure minus total PEEP is called the driving pressure. And this driving pressure represents the tidal volume indexed by the respiratory system compliance. Driving pressure reflects the functional size of the lung and gives an idea of the size of the baby lung. Amato has explored a lot of patients with ARDS coming from 9 randomized studies and has explored the question whether a lower driving pressure was associated with a lower mortality. And the answer was yes, with a threshold around 15 centimeters of water. More than 15 was associated with higher mortality. This was found also in the lung-safe observational study, where driving pressure lower than 15 was associated with lower mortality. For driving pressure, is the lower the better? Based on the data from Amato, we can say that the answer is probably yes. You can see on the right part of this slide that if we compare patients with the same plateau pressure, but with different driving pressure, the mortality was the lowest when the driving pressure was the lowest. But to further decrease driving pressure, VT must be reduced. And is it possible to reduce VT as far as 4 milliliters by kilo predicted body weight? Richard and collaborators have explored this question. They have applied the strategy of ventilating the patient with a tidal volume of 4 milliliters by kilo in 35 ARDS patients. At day 2 after inclusion, they found that a tidal volume of less than 4.2 milliliters by kilo could be applied in 22 patients, 2/3 of the patients. And they found that this very low tidal volume was associated with a reduction in driving pressure of 4 centimeters of water. Please note that PEEP was also increased from day 0 to day 2. And what was the consequence of that? You can see that PaCO2 was, as expected, a bit higher, and pH was lower. Overall, severe acidosis, defined by a pH of less than 7.15, occurred in 11 patients, 1/3 of the patient. 2 patients developed acute cor pulmonale, and the right ventricle over left ventricle ratio tended to increase, but this was not statistically significant. Then overall, the strategy could be applied in 2/3 of patients with a price to pay, which was severe acidosis in 1/3 of the patients. Then, what can we say about setting tidal volume? I can propose a physiology-based approach to titrate tidal volume. First, begin with tidal volume of 6. Then, optimize PEEP, keeping plateau pressure under 28 to 30 centimeters of water. Then, assess driving pressure. If driving pressure is more than 15, consider reducing tidal volume by 1 milliliter by kilo steps and increase respiratory rate, monitor pH, PaCO2, and right ventricular function. If driving pressure is lower than 15, then look at other physiological variables to try to keep them in a physiologic range. If it's the case, keep tidal volume at 6. If not, maybe try to increase tidal volume a bit, up to 8 milliliters by kilo. But if you do that, do not forget to check plateau pressure that has to be kept lower than 30, and also check again driving pressure. This is a physiology-based approach to titrate tidal volume in our patient. But of course, this approach has to be tested before being recommended as a by default approach. Thanks for your attention.